Good afternoon. This is Ronald Giffler, your FMA president. This is the seventh, I believe, in a series of Friday noon town hall type web meetings to specifically help us financially and operationally have our practices survive through the COVID epidemic. It's been 2 weeks since our last meeting, and it's been quite a 2 weeks. Highlighted by that brutal death in Minneapolis of Mr. Floyd, and then by violence and riots and protests all across the country. When our offices were just starting to open, now we're faced with yet another and a very serious national threat. So I think it's very timely to have this program, as our governor has, except for the Southeast counties where I happen to reside, moved to phase 2 of his reopen Florida. So our first speaker is no stranger to you all. It's Jeff Scott, our general counsel, and he's going to give us a legal and advocacy update with regard to changes relating to phase 2 and any other significant changes that we need to know. So I will turn the program over to Jeff. Thank you.
Thank you, Dr. Giffler, and thank you for letting me go first. Jarrod's presentation is going to be far more interesting, so I appreciate the ability to be his setup act. I want to talk to you about a couple of emergency / executive orders that have been entered into since the last time I gave an update on this webinar. The first is emergency order number 20-002. This order has been extended about 3 or 4 times already. It was set to expire on May 31st, and it has now been extended until June 30th. This order, you may remember, is the one that allows physicians to prescribe controlled substances to patients with chronic non-malignant pain, existing patients, and allows them to certify patients for medical marijuana if they are an existing patient without having to do an in-person examination, i.e. via telehealth. So we had a number of physicians who have been providing this service and want to be able to continue to provide this service. The FMA will certainly advocate for the extension of this particular ability during the existence of the public health emergency, and then we'll explore other avenues to make this available to physicians so that they can continue treating patients in a manner that has proven to be beneficial for both. So that again will be extended until June 30th. I don't know if it's going to be extended again yet another time, and we probably won't know until July 1st, if history is any indication. The second order, Dr. Giffler alluded to, Executive Order 20-139. This moves most counties in the state into phase 2, effective as of today. And while there's not much of importance for physicians or healthcare providers new in this particular order, it is interesting to note that there are a number of provisions in here that are encouraged but not mandated. And it's an interesting distinction that I think has gone unnoticed. But there's 4 provisions. One, senior citizens and those with underlying conditions are encouraged to avoid crowds and limit their exposure of individuals with COVID-19. Yet that's not a mandate. They're not required to do that. They're strongly encouraged. Groups of larger than 50 persons are encouraged not to congregate. Yet again, not a mandate, but something that the state strongly encourages groups to do. Workers in long-term care facilities should be tested on a routine basis, and in-store retail businesses should maintain appropriate social distancing and sanitation measures. Again, all of these are items that the state is encouraging, but not mandating, and they're not punishable if by law if you fail to do these. There's no expiration date yet given on for the move to phase 2, and I have no idea as to when the governor is going to move us to phase 3. It may be a while given the uptick in reported sections that have come out recently, but at this time I have no indication when that will happen, and I think I'm not even sure that the governor really knows right now when we're going to move into full phase 3. So those are the emergency orders, and things that have happened since the last update. I want to give you an update now on a federal law provision that was enacted back in March. Since most physician practices are now up and running, the federal public health emergency is still in effect, and this federal law and the benefits that it provides are still in effect and applicable to physicians and physician and practices. I want to give a brief rundown on what this does. And this federal law is H.R. 6201. It's the Families First Coronavirus Response Act. And I want to give a little update on what it means for you as a physician employer and a physician employee. Now, this federal law requires employers with less than 500 employees to provide certain mandated benefits to their employees. This provision act became effective on April 2nd. It is set to expire unless extended on December 31st, 2020, and it is not retroactive. It is applicable going forward as of April 2nd. And there's two main benefits that this act provides to employees, and the first is the expanded family and medical leave under the Emergency Family and Medical Leave Expansion Act. Now, this is a expansion, obviously, of the current existing benefits that are provided under the Family and Medical Leave Act. This particular one provides 12 weeks of job-protected leave. And to be eligible, an employee must have been on the employer's payroll for 30 days prior to the leave request. And what this provision, the benefit, it's limited, and it is much different than the Unpaid Leave Act that I'm going to talk about next. This one provides an eligible employee with job-protected leave to take care of a son or daughter under the age of 18 when their school or place of care has been closed or their regular child care provider is unavailable due to the public health emergency with respect to COVID-19. So it is a limited benefit that's applicable only for you to take care of your child when their daycare or school is unavailable. And that doesn't mean that it's available when school is normally out. This has to be a shutdown that is due to the corona health virus in particular. The first 10 days of leave under this act may be unpaid, but unlike leave under the original Family Medical Leave Act, employees are then entitled to 10 weeks of paid leave at no less than 2/3 of the employee's usual rate of pay. Such paid leave is not to exceed $200 per day and $10,000 in the aggregate. And this job leave is protected. You, as an employer, are obligated to return your employee to the same or similar position upon their return to work. You cannot fire, discipline, or discriminate against an employee who chooses to take this particular leave. You can, however, take regular employment actions that you would have taken regardless of whether this leave was taken, such as shut down your job site, close your business, lay off, or furlough your employees. There are some exceptions to the ability to take this leave. If, as an employer, you have less than 50 employees, you may be excluded from the provisions of this Expansion Act if the provision of this particular leave would result in financial obligations exceeding business revenues and would lead to your business being no longer able to operate at minimal capacity. If the absence of employees requesting this leave would entail a substantial risk to the financial health or operation capabilities of your business, or if there are simply not enough workers who are able, willing, and qualified and available to perform the services needed by an employee who is requesting leave, then you are not obligated to provide this leave under this act. The next exception is probably the one most important for this particular audience. If you are a healthcare provider, you may be excluded from the expanded family and medical leave. And I guess this makes sense in an odd sort of way. You would think that the federal government would want to protect healthcare workers who are on the front lines of the pandemic providing care and provide this benefit to them. But they took the tack that they want to ensure that the healthcare workforce is available to take care of COVID-19 patients. So they have exempted them from the leave mandated under this act. So if you are a physician, a nurse, a PA, or any other licensed healthcare provider, or you're employed by a doctor's office, a hospital, a healthcare center, medical school, county health department, retirement facility, nursing home, pharmacy, any other similar institution, or you are an employer, you're employed by an entity who is providing services to one of the institutions mentioned to maintain, so that institution can maintain their operations, you may be excluded from taking this Expanded Family and Medical Leave Act. And the same thing applies for emergency first responders. So obviously that's a big exception that's applicable to everyone on this call. The federal government, the Department of Labor, has encouraged such healthcare employers to make this leave available to their employees if at all possible, but it is not mandated under the Act. The second provision in HR 6201 I want to talk about is the Emergency Paid Sick Leave Act. And this is, it's similar, but it's a different benefit and it's applicable in more situations. And this provides full-time employees with 2 weeks, 80 hours of paid sick leave for the following reasons. If the employee is subject to a COVID-19 quarantine, if the employee has been advised by a healthcare provider to self-quarantine due to COVID-19 concerns, if the employee is experiencing symptoms of COVID-19 and seeking a diagnosis, if the employee is caring for an individual who is quarantined and who has been advised to self-quarantine, or if the employee is caring for a child, if the child's school or place of care has been closed, or the care provider is unavailable due to COVID-19 precautions. For all of those reasons, those individuals are entitled to 2 weeks of paid sick leave. The paid sick leave under this act is available to all employees, regardless of how long they've been employed. There is no 30-day requirement, such as with the FMLA. The employer cannot condition the provision of this paid sick leave on the employee finding a replacement to cover their hours worked. They simply have to provide it regardless of whether an individual is available to fill in or not. The employer may not require an employee to use other available paid sick leave before using the paid sick leave provided under this act. This is a first round benefit. This is available to you regardless of whether you have paid sick leave provided by your employer for other reasons. If the employee is taking paid sick leave under this act, they're entitled to their regular rate of pay, depending on the reason for which they're taking the leave. So if they're taking the leave under this act because they are quarantined or they are seeking a diagnosis, they are entitled to their full regular rate of pay, limited, however, to $511 per day or $5,100 in the aggregate. If, however, the employee is taking this leave to care for a child whose daycare is no longer available or for an individual is quarantined, they are entitled to 2/3 of their regular rate of pay, not to exceed $200 per day or $2,000 in the aggregate. And as with the FMLA, you may not discharge, discipline, or discriminate against an individual who chooses to use their leave under this act. And the exemption for healthcare providers that I explained under the FMLA is equally applicable in this situation as well. So if you are a physician employee, this particular leave may not be available to you. Now, employers are entitled to tax credits for the paid leave. And there's a tax credit system that is available for you to use. And the explanation of this delves into Jarrod territory. And so I'm not going to get into that in detail. If you have any questions about anything related to this, to the FMLA or the Unpaid Paid Leave Act, feel free to contact me here at the FMA at jscott@flmedical.org. If it's something that related to the financial aspect of this, I'll get Jarrod to help. But if you got any questions about any other provision of law, any emergency order, or anything else, please contact me, and we'll be happy to help as best we can. Thank you for your membership, and Dr. Gifler, that's all I have.
Thank you. And thank you for your comments. I want to remind everyone that our mission is to help physicians practice medicine. So Jeff really means what he says. We are open and available to help you. There is a chat box here. You can type in questions today also, and perhaps get a quicker answer than waiting for the phone. Try and keep your questions short, and you can put them in now, and we can get back to Jeff after Jarrod's presentation if they're legal in nature. But with that, we'll move on to Jarrod. For those of you that don't know Jarrod, he's the Director of Healthcare Policy and Innovation at the Florida Medical Association, and his responsibility is to analyze state and federal data on regulations and finances and on all kinds of things related to keeping our practices viable. This is going to be a slight alteration from our usual presentation, where we're going to try and get some predictions for the rest of this year, which has proved like no other that I can recall in my career. And we're looking forward to what Jarrod's comments are for predicting the rest of this unprecedented year. So Jarrod, thank you for sharing your insight with us this afternoon.
Hey, thank you, Dr. Gifler. So hopefully everybody can see my PowerPoint here. As Dr. Gifler mentioned, we're going to kind of step back today, look a little bit more at the big picture. In the past, generally when I speak, I'm talking about a specific financial program that is applicable to physicians. A lot, as you know, has happened just over the course of the past few months with changes to telehealth and to reimbursement for a variety of services, to funds that have been made available by HHS, to programs created under the CARES Act, such as the PPP. It's just been, on so many levels and in so many ways, a year where there's just been nonstop and difficult to predict change. So today, again, in looking at the big picture, I'm going to go ahead and I'll make some predictions and talk a little bit about what we can kind of expect going forward. I'm also going to kind of talk you through what the impact looks like at a 20,000-foot view in terms of the effect of the pandemic on physician practices financially. I do not warranty my predictions. This has been an unpredictable year, and so anything I predict, I fully admit with a great deal of humility, I may be completely wrong, but I've done my best to make some predictions that I nevertheless hope will be helpful just in giving you an idea of what we might anticipate looking forward. So I want to start with a chart. This has been a year with just any number of stunning statistics, and this is one that I personally found to be perhaps most stunning of all. As you know, the cost of healthcare in the aggregate in the United States has been growing for many, many years. You can see from this chart here, spending on healthcare services. These are like things like physician services, dental services, hospital services, but not pharmaceutical drugs are over the course of the past several decades, from 1960 up till present day. And what you can see is that always spending on healthcare services has grown. It has grown, exponentially. And for the first time, even, amidst pandemics, amidst recessions, amidst, any sort of, anything that you can imagine that's happened, in the United States or in the world, we've never seen spending on healthcare services decline. Even during the Great Recession, you can see that the general trend was upward. But in April of 2020, there was a 38% decline. Sudden decline in expenditures on healthcare services. And you can see just how unprecedented that is by looking at this graph. This takes us back to spending levels not seen since the early to mid-aughts. This has, if you break this out by service, you can see that dentists actually saw the largest decline at 61%. And physicians and physician services actually declined by 45%, more so than hospitals, more so than home health care, more so than lab services. And you can also see from here that nursing home spending actually grew a little bit from April 2019 to April 2020. There has just been an an enormous reduction in expenditures, and that's really, as you can see from that previous graph, just something that is unprecedented. And so another way in which we can kind of look at the impact by industry, and looking here specifically at physician practices, just today, the Bureau of Labor Statistics released information on jobs. And we could see back in 2020, this is in thousands, physician offices employed, well north of 2 million individuals, 2.7 million individuals roughly. And from March 2020 to April 2020 in physician offices, 263,400 jobs were lost. However, between April and May, 51,300 jobs were gained. And so you can see there, what a tremendous drop off there was, and that there has started to be, based on this data, somewhat of a recovery in terms of physician offices with respect to employment. And I'm going to show you some other data to kind of show how things have changed as well in terms of reimbursement. And you can see, in relation to hospitals, which obviously employ a lot more people, they actually continue to lose employees between April and May. They lost another 26,700 jobs in hospitals between April 2020 and May 2020. So you can see here that physician offices have just started to recover in terms of job losses. That hospitals are still shedding a few jobs, but we can see here, at least with physician practices, that the trend is starting to come back upwards. And this is something that's reflected here as well. This is data from a study that the Commonwealth Fund put together showing changes in ambulatory provider visits over time. And they sort of use the first week of March as sort of a baseline. Through March the 7th in terms of a baseline level of ambulatory visits. And you can see by March 29th, relative to that baseline, ambulatory visits were down 58%, which is really quite stunning. And by the time that we reached May 10th, that had rebounded somewhat, although ambulatory visits were still down in the aggregate 31% relative to the baseline period. Something that is not going to shock a lot of you is that a great deal of this, and I know that there's a lot of information here, but unfortunately it's an interactive slide on the website that I got this from the Commonwealth Fund, but I have no way to make it interactive here on the PowerPoint, so you have to kind of bear with me. The bottom is that we're seeing that this recovery has been driven not entirely but substantially by an increase in telehealth services. The majority of the recovery still comes from gains in in-person services, but telemedicine has helped tremendously with helping some of these ambulatory provider visits recover in terms of their overall number utilization. So you can see again from the baseline period, from the first week of March to March 29th, there was a 67% reduction in in-person ambulatory visits. But if you included telehealth, that dropped to the aforementioned 58%. And by 5/10, you can see in the aggregate, there was a 31% reduction, as I mentioned, in overall reduction in ambulatory provider visits. But there was still a 44% reduction in in-person visits. In other words, had it not been for telemedicine, had it not been for the increased utilization of telemedicine and providers shifting to more telemedicine services and being able to take advantage of that, physician practices with respect to the proportion of visits that they have shed since the onset of the pandemic would be much greater. You would have potentially, if all visits had to be in person, still a 44% reduction in visits versus a 31% reduction that we've seen instead due to the effects of telemedicine. So telemedicine has lessened the effect of the pandemic with respect to ambulatory visits for providers by quite a substantial amount. Another data point around this whole telehealth issue, I'm using the term telehealth instead of telemedicine here because that's just the term that was used in this particular study. The volume of telehealth service claims from March 2019 to March 2020 grew 4,346.94%, from 0.17% of claims to 7.52% of claims, and this comes from the Fair Health database, which is one of the largest claims databases in the nation. You can see there has just been tremendous growth, and as a result of that, I am, very much inclined to believe that a lot of the flexibilities that we've seen around telehealth are likely going to stick around for some time. We know that CMS has said that they intend to continue their telehealth flexibilities through the end of the PHE. But there's no indication of when the PHE will end, of course. Conceivably, that may not end until a widespread vaccination is available. And this has made me increasingly optimistic that many of the flexibilities provided in the telehealth or telemedicine space will be made permanent. You can see just the absolutely gigantic amount of growth, and again, the enormous effect of telemedicine in terms of helping practices recover from the pandemic by substituting in-person visits for some more telemedicine visits. So we know that the impact of the pandemic has not been even across specialties. Another thing that the Commonwealth Fund has done a very good job of is sort of breaking out the impact by specialty. And you can see, for example, ophthalmology saw the largest reduction in terms of visits from the baseline period to and now up until May 10th. Ophthalmology at the height of the pandemic lost 79% of visits based on this analysis from the Commonwealth Fund. And they have since recovered as of 5/10. They are down only 39%, which is still obviously tremendous, but you can see again just a major recovery there. And that's important. You can see that most specialties are recovering. This orange line here represents sort of losses at the height of the pandemic in terms of a reduction in services, office services, and the green lines indicate where practices were on May 10th. And you can see again that there's been a big recovery, that the practices are not down nearly as much as of the end of the May. And so that is something that we can say is a good trend. Obviously, very few businesses still can sustain long-term 30% reductions in their service revenue, but at least we can see that as more practices open back up, things are moving somewhat in the right direction. There has been one exception to this that I think is notable, and that we have to touch on. Pediatricians at the height of the pandemic, their office visits were down 62%. And they remain down 45%, which is greater than any other specialty that you see here. And so pediatricians, based on this data from the Commonwealth Fund, have really suffered disproportionately in this pandemic. That's not to say that everyone else, hasn't as well. In general, if you look at this, you'll notice that procedural specialists have seen greater reductions in service volume relative to primary care specialists and non-procedural specialists, but the pediatricians in particular have taken a really big disproportionate hit according to these data. So that begs an important question, which is what are we going to do about funding for Medicaid providers? This is something that's come up a lot because providers who did not treat Medicare patients in 2019 were ineligible for the general distribution funds made available by HHS, which constituted $50 billion in the aggregate. Pediatricians, again, they've been disproportionately impacted, but many pediatricians did not see any Medicare patients in 2019, and therefore were for these funds. What we're hearing, fortunately, though, from our contacts is that although funds are still not available as of this time to go to Medicaid providers who did not qualify for the general distribution, Congress is aware of this delay, and a bipartisan group of congresspersons have sent a letter to HHS asking for the release of these funds to come as soon as possible and questioning why they had not been made available sooner. And according to our contacts at the AMA, HHS is currently beta testing a website that they are going to use to accept applications from providers who were not eligible for the general distribution. There was no definitive ETA. We were told, in a couple of weeks is the approximate ETA. But do know that this is something that we deeply care about. This is something that's being worked on, and the data speak for themselves. The pediatricians do need help. The Medicaid providers generally need help, but again, at least from what we have seen, in general, things are moving in the right direction as far as office visits continuing to rebound. after the height of the pandemic, and we're optimistic that that is something that will continue to move in the right direction. So here's here's something that many of you may have forgotten about, which is every year CMS releases a new Medicare physician fee schedule rule. And this fee schedule rule these days, it covers not only changes to the relative values of various Medicare codes, various CPT codes that are paid for by Medicare, but it also tends to include changes to the quality payment program, that is MIPS and APMs under MACRA. And in the past, we've seen that CMS hasn't necessarily hesitated to put out some very controversial rules. For instance, in 2018, many of you may remember that CMS put out a rule that would have collapsed the 5 levels of payments for evaluation and management codes to only 2 levels of payment. And after an uproar from your FMA and every other medical association in the nation, I believe, that was beaten back. And while CMS has made some more modest changes to documentation for E&M codes that have been relatively positive, something that hasn't gotten a lot of attention is that in 2019, when CMS released its last physician fee schedule rule, they said that effective in 2021, they were going to implement several changes that were less extreme than what they had previously proposed to E&M codes that were we nevertheless need to talk about because they could have a very substantial impact if CMS follows through with them. So in 2019, CMS said that in 2021, next year, they want to dramatically increase the value of evaluation and management codes that take place in an office or ambulatory setting. And this in and of itself, was recommended by the RUC, recommended by the AMA's group of experts, and it is something that would have generally been a good change. But CMS departed from the RUC in 2 crucial areas that were problematic. They said in 2021, we don't want to just increase the evaluation of E&M codes just by itself. We also want to create a new add-on code that would further increase the valuation of E&M codes for patients who are medically complex. And furthermore, they did not want to apply these changes to E&M codes that were included as part of surgical bundles. That it would only apply to E&M codes that took place in an office or ambulatory setting, but that were not bundled with surgical codes. And the effects of this in the aggregate meant that were these changes adopted in 2021, there would be a substantial redistribution of funds to providers, to physicians who code using office visits, E&M codes very frequently, and away from providers who do not code using evaluation and management codes in an office or ambulatory setting very frequently. Writ large, it would basically move money towards the so-called cognitive specialist and primary care specialist and away from procedural specialists. You can see here, this is just a sample. They do this for every single specialty. And so, at the end, if someone wants to know what the effect is on a given specialty, I can tell you where to find this data, or I can provide you with an answer to how a specific specialty would be projected to be impacted. But in 2021, if these changes were adopted, family medicine would see, according to CMS, a roughly 12% increase in Medicare expenditures that they would receive. Neurology would receive an additional 8% over baseline, and cardiac surgery, for example, would receive an 8% reduction, and anesthesiology would receive a 7% reduction. And in general, again, procedural specialists would see a reduction, whereas the so-called, what we would broadly refer to as a cognitive specialist and primary care specialists would receive increases. And so that is something just to be aware of. My personal prediction is that CMS is going to scale this back. We should have a proposed rule pretty soon. And finalize probably within the next month. And I do not anticipate that CMS is going to move forward with these very drastic changes that would shift, as much as 16% of revenue around under the Medicare physician fee schedule between specialists, given the environment where we already have a lot of volatility and a lot of people need certainty with respect to how much revenue they can project. I think that CMS will, again, this is just my prediction for what it's worth, will walk back their changes to be more in line with what the RUC recommended, which would be a general increase in the valuation of E&M codes, but without these additional add-on changes and without, excluding E&M codes that are calculated as part of surgical bundles bundles, thereby leading again just to an all-around more modest increase in fees for some of the non-procedural specialists and primary care physicians. You have to keep in mind too that the reason that some people win and some people lose under the Medicare physician fee schedule whenever CMS moves money around is that by law they have to implement this on a budget neutral basis. And so if they want to dramatically increase payments, say for E&M codes, they're going to have to come up with the money from somewhere. They're going to have to cut it from somewhere. And that is unfortunate. Unfortunately, that's a part of law. That is a part of the law that we would very much support repealing. But that is been something that's been in the law for some time, and it's something unfortunately that's been very hard to change. Consequently, if CMS makes changes that are too dramatic in terms of shifting money around from one type of service to another, the effects in the aggregate may not change. In the aggregate, the amount of money spent will not change, but the impact on any given specialty can be dramatic because, again, you have to take from somewhere to give to somewhere else. I also predict that CMS will provide some sort of relief for the 2020 reporting year for the quality payment program. So as many of you know, in 2019, for the 2019 reporting year, CMS offered a lot of relief to providers that were having trouble reporting data under the certainly nobody should act as if there's going to be additional relief for providers under the 2020 reporting year. I do not encourage you to change your behavior as a result of this prediction, but I do anticipate that CMS, recognizing the effects of the pandemic and the effects of that has had on physician practices and their ability to report data, I am optimistic that they will provide some additional relief, perhaps in the form of extreme and uncontrollable circumstances policies that would allow for substantial reporting relief for providers who were in MIPS in 2020. That is the next prediction that I will make concerning the Medicare physician fee schedule. So the PPP, as many of you know, it's funny. So I wrote this slide. I wrote this slide. I intentionally waited until this morning to fill this in because what we've learned is that Congress has made some changes to the PPP. It passed near unanimously, all but one vote in the House and unanimously in the Senate. And I put here that it's that these changes are awaiting President Trump's signature, but that's no longer true. President Trump has now signed these changes in the law. So there were changes to the PPP that were passed by Congress and today signed by the president. I'm not going to go over all of the changes that were made, and we have an accounting firm, CRI, that we work with that's going to fully analyze this legislation now that's been signed into law so that we can provide our members with some in-depth information on what the effects will be. But there were among the most substantial changes that were included in the bill. The legislation provided more time to spend funds to qualify for loan forgiveness. The so-called covered period increased from 8 weeks to 24 weeks, which hopefully will make it easier for a lot of folks to qualify for loan forgiveness. And it changes the so-called 75-25 rule that required folks to spend 75% of the funds on that they received under the PPP on payroll costs and only 25% on other eligible expenses. Under the legislation, up to 40% of funds can be spent on eligible non-payroll costs. And stay again tuned for more detailed information. That's something that CRI is going to work on and that we will have information to share with you in the near future. So the last thing I'm going to bring up here is just the phase 4 package. What's going to happen potentially in Congress? Are they going to pass another bill? We had a call last night with our consultants in Washington, D.C., who work with us, and this is something we've been very closely monitoring in general. We know that Congress is debating what they would call a phase 4 package that the Senate wants to limit to $1 trillion. So it would be, potentially a somewhat smaller relief package, relative to the CARES Act. The House and Senate will surely have some back and forth in terms of how much money to spend and what to be included. But I wanted to briefly mention sort of the opportunities and risks associated with any new legislation. The opportunities here include, opportunities for tort reform, which is important to any number of businesses as they recover from the pandemic, but also to physician practices as well as they start to bring people back. And there are all types of just uncontrollable circumstances that providers have been faced with as a result of this horrible disease, and any opportunity to provide providers with a little more certainty in the tort space would be great. Additional provider relief is something that is a possibility as well. I want to note that, previously under the past two pieces of legislation that have gone through Congress, $175 billion has been appropriated to HHS. And so far, HHS has only spent roughly $75 billion of that $175 billion. So there's still a tremendous amount of money that they could still spend that's available, that's already been appropriated. There's still a question of how they're going to disperse those remaining funds. As I mentioned, there will be some relief coming to Medicaid providers, but even then, there would still likely be at least 80 billion left in all likelihood. But there is still at least a possibility of getting some additional financial relief, which we believe is still sorely needed in the next piece of legislation. It would be, we think, something that would. We ultimately we don't believe that the funds that remain unspent are going to be enough in the aggregate. We have something like a $3.8 trillion a year healthcare system. $175 billion is a lot of money, but given the size of the healthcare system, and how much money has been lost in the course of this pandemic, $175 billion may simply not be enough to make a lot of folks whole and to ensure that we don't have physician offices and hospitals and so forth shuttering. So I do still believe, and I would anticipate that there will be additional funding for provider relief included in the Phase 4 package if one is passed. Again, that's just my prediction. I don't warranty it, but I think that there's a lot of wisdom in including some additional, and I believe that they're objectively needed. And so I would anticipate that there will be some, again, I may be wrong, but that is something I would throw out there. Risks. As far as things that could go wrong in this legislation, surprise medical billing is still something that is out there. The push for it at the White House level is still ongoing. There are still senators and members of the House on both sides that want to see surprise medical billing addressed as soon as possible. However, we have heard, fortunately, that Senate leadership is not necessarily interested in rolling a surprise medical billing provision into the NETS package. For the record, we support addressing surprise medical billing as long as we can do it in a way that doesn't harm patients or reduce or harm physicians to take away their leverage and give more leverage to insurance companies. We want to have a balanced approach. We've supported one all along. Many of you are familiar with the Roe Ruiz legislation that we've come out in support of. And I think our members know that, we would oppose any approach to surprise medical billing that would harm our members or harm their patients. But nevertheless, that is just an area where we will have to remain vigilant because, Congress is now considering a new approach to surprise medical billing. The language for it is still, as of this time, unavailable. But the latest rumor is that there is a recommendation floating around that surprise medical billing be addressed simply by creating a flat ban or prohibition on surprise medical billing with no sort of back-end resolution process, no sort of IDR, no any kind of appeals mechanism. And again, that language isn't available yet, but that is something that is very disconcerting that has been floated out there. And we have already been in very close touch, both with our lobbyists in DC, as well as with the AMA and other medical societies to make sure that we're monitoring this extremely closely and that we're aware of what's going on so that we can act to try to address any sort of bad legislation that might be pushed. And with that, I will close. Thank you for what you do. Thank you for joining this webinar. I hope some of the data and information that I provided has been helpful. I welcome any sort of feedback. This is a little bit of a departure from a previous sort of webinar format, and I look forward to answering any sort of questions.
Thank you very much, Jarrod. That was fascinating slides to really highlight how severe the economic downturn has been for much of our practices. Hopefully, we will be continuing to be on the road to recovery. There are no other questions in the chat box. If anybody has one, I suggest they get their fingers moving pretty quickly. Otherwise, we're going to be finishing a few minutes early. I want to thank Jarrod. And
we have a few questions.
Are there more?
Yes, sir. We have some questions that people have sent over.
Okay.
I'll start running through them. I think the first few are going to be for Jeff. Does sick leave cover an employee who is recommended quarantine after a peaceful protest?
If the patient has been recommended to quarantine by a healthcare provider, it doesn't matter what the reason as to why they are being quarantined. If it's for COVID-19, then yes, the sick leave provisions would cover that. The employee would be entitled to sick leave under the sick leave provisions of the HR 6201.
On the same area, can paid sick leave be used more than once?
You get 80 hours. You don't have to use them consecutively, but once you've used those 80 hours, example, if you've used your 80 hours for quarantine, then you don't get another 80 hours to use for one of the other reasons, such as the care for an individual who's been quarantined. So you get an 80 hours total. Once you've utilized all of that, that's all you get.
Okay. And if they have a recurrence, can they use another 2 weeks of paid sick leave?
No, you get 80 hours of paid sick leave. Once you've used your 80 hours, that's all you get.
Gotcha. Okay, looks like we have some questions for Jarrod here. Jarrod, do you have any data on the breakdown of jobs lost at hospitals, meaning administration versus physicians or support staff?
Hey, that's a great question. I pulled up the BLS page here, and I do not see any sort of breakdown on that in the data that's provided. I can send a link to this to anybody who's interested. They do it by broad industry, so they break down offices of physicians, dentists, other healthcare practitioners, outpatient care centers, home health, other ambulatory centers, and then they have hospitals, and then they break that out into different types of hospitals, but I don't see that based on like what type of profession. I will search the BLS database to see if they provide any more granular data. This is something that literally just came out today, this report, but I thought it was really fascinating data, so I wanted to go ahead and give it to y'all.
Okay, and this one can kind of go to Jeff and Jarrod. What's the status of continuation of telemedicine services, i.e. HIPAA relaxation and payment parity after the end of the national emergency order? Can you summarize the effort of the FMA in this area?
Yeah, so as it stands, the flexibilities that are provided, with respect to reimbursement for telehealth services are to continue through the duration of the PHE. We do not know when the PHE will end. But again, the PHE could conceivably extend until there's a widespread vaccine available, some sort of vaccine that's been widely distributed that people have, broad access to. Quite frankly, it could extend longer. We really don't know. But I can say that there's a huge push already in medicine to make some of these changes permanent as far as the flexibilities that have been provided on the telehealth reimbursement side. Because, as you've seen from some of the data that I provided earlier, there's been, a huge uptick in the use of telehealth in a very short period of time. And that's been instrumental in helping practice to stay afloat during this period. On the HIPAA side, I would defer to Jeff just to make sure there's nothing that, that he knows that I may not be aware of with respect to that.
Oh, what's the question as far as HIPAA? I didn't see that.
Will the relaxation of HIPAA laws, how long do we feel that will extend?
As long as the public health emergency is in effect. The Department of Labor and the entity that's responsible for enforcement of HIPAA has indicated that they're not going to be enforcing that during the public health emergency. So I suspect that will last as long as the Medicare provision allowing for payment lasts. So payment parity has been something that the FMA has been seeking for prior to the pandemic. So I'm hopeful that this is going to give us a good opportunity in the Florida legislature to go in and have a basis to argue that this needs to continue, and that the Medicare position should be adopted by all commercial insurers in the state of Florida, and that's something that I'm relatively certain that the FMA will be working on in the next legislative session.
Yes, and also there's strong push from organized medicine to hopefully address some of this in the next COVID package, especially around ERISA plans that may not be subject to some of the requirements as other types of plans. As Jeff mentioned, ultimately we need legislation specific to Florida to make sure that the commercial insurance companies here, whether regulated under ERISA or not, would ultimately be required to provide telehealth services. Obviously, the ERISA issue would be that, in the event that legislation were passed in Florida without some sort of action by Congress, the requirement would not extend to plans that are self-funded large group plans, those that are covered under ERISA. And so there's congressional action needed as well. And we're fighting on both fronts to get that.
All right, I think this one's for Jeff. About DeSantis's order for having all prospective patients self-quarantine for 14 days pre-operative from New York, New Jersey, et cetera. When do you feel this order will expire?
That particular order was extended in the latest executive order from the governor. There is a quarantine provision for both incoming flights and individuals who travel in via land. I know that there's been one particular doctor who's been very interested in this, and I've been following that. But as to when that he's going to let that expire or not renew that, I do not know.
Okay. I have another one, Jeff or Jarrod, if you want to take this. With the position of anesthesiologists have held leading the team in providing care for COVID-19 patients, what is the rationale behind them getting pay cuts, and would there possibly be any possibility for hazard pay?
So good question. With respect to the pay cuts, that is with respect to the proposed changes that would take effect in 2021 under the physician fee schedule as it was released in 2019. That is based on basically the way that occurs is by because the increases in evaluation and management codes would not apply to anesthesiologists. And because the increased payment and evaluation management codes would have to then, come out from somewhere else, right? It has to be paid for by across-the-board reductions for other types of services. The reduction to anesthesia and the reduction to other types of procedural specialists that see cuts are not targeted at those specific specialties. Rather, what's happening is, again, since they're increasing the valuation of evaluation management codes, that the aggregate cost of that has to come out of somewhere. And the way that they do it, in this proposed rule is that they do an across the board cut to the conversion factor, the thing you multiply your RVUs by, to figure out, what they're worth. And that across the board reduction, when you add it up, in the case of anesthesia, given just the way in which they historically bill, CMS estimates that the effect on that particular specialty will be minus 7%. We don't support a reduction in pay to any specialty under the Medicare physician fee schedule. We support ending the budget neutrality requirement that forces this sort of math wherein, the only way to increase pay for services is to decrease them elsewhere. We don't support that at all. Other, specialists that are adversely impacted here include pathologists, various types of surgical specialists, ophthalmologists, plastic surgeons, and any number of other types of procedural specialists. Again, I'm hoping that CMS will scale back this proposal. Therefore, and were that to happen, of course, you would see much smaller changes in the valuation of payments to various types of specialists. And in terms of hazard pay, I think that there will be a push for that. However, remember, the Senate is wanting to keep this net bill to $1 trillion is what we're hearing. And I don't know how much hazard pay would cost, but obviously spending is going to be a factor. It's something that's going to have to be, considered. So I don't really know how to place the odds of that, because I think a lot of that is contingent on, how much is spent under the legislation and how many other priorities there are and how much those other priorities cost. And I think that we're still so very much in the early stages. So there's not an easy way to place that at this time. You could also imagine target pay only being provided up to and including a certain pay level. There are all different types of ways they might target it that can impact the availability of those funds. But I do think it's a good question and something that we're looking at and advocating for.
Hey, Jarrod, could you speak to any economic relief available specifically for an independent contractor or locum tenens physician?
The general distribution funds would have affected, just about anybody who billed for Medicare in 2019. I'm not personally aware of a targeted distribution to that group. So CMS breaks out their funding of or HHS rather breaks out their funding of the provider relief into two categories, which is a general distribution, which was available to anybody who met a set, of criteria, billing for Medicare in 2019. Being the major one. And then targeted distributions to heavily impacted providers, providing uncompensated care to physicians who see, COVID-19 positive or potentially positive patients and things of that nature. So I'm not aware of anything that applies specifically locum tenens physicians or to contractors, but I would think that the substantial majority of them would have been eligible for funds under the general distribution as they would meet those criteria. But if somebody is saying that they appear to meet the criteria for the general distribution, receive funds under that program, then I would urge them to contact me so that we can figure out what's going on there.
Matt, I'd just like to add, this question has come up several times in the course of our discussions, and independent contractors are treated as independent employers. Employers cannot get funds for them like their other employees. They're a separate, independent, considered employer and are entitled to all the benefits that employers are. They just have to do it themselves if they're working by themselves.
I also want to just make sure that we're aware with that question if we're referring to the PPP or to the funds that HHS has provided, because I realize now we could be talking about any number of things. That is something I need to back up and clarify, because I assumed that the question was related to funds under the HHS general distribution, but this may have been related to the PPP or to other sorts of relief programs. So I think we would need a little more detail. I would have to say then in lieu of being able to answer that question directly, to make sure that we know which program we're talking about and everything else, if we could get the email address of whoever sent that, so that we can respond to it on a more specific level, that would be helpful.
Yeah, that's a good point.
And there may be unemployment compensation funds available as well, so that depending on the circumstances, so that would be something you could look into.
Jarrod, are there any significant bundles of federal money available to us where the deadline to apply has not yet expired?
So with respect to the targeted distributions, one thing that's ongoing is there's a relief fund available for providers who treat uninsured patients related and provide care related to COVID-19 on HHS's website. They continue to have information related to that. Here's something that I've learned, over the past couple of months, which is that HHS changes their guidance a lot, and they still have $100 billion left to spend. The majority of their money is still on the table. Of the $175 billion that's been appropriated by Congress, they've spent about 75. The HHS Provider Relief website is updated, sometimes multiple times per week with new information. They will be rolling out new programs. They will be spending new money. But what I would, so I mentioned, relief for Medicaid providers is still coming. So obviously there hasn't been any sort of deadline associated with that. There may still be instances where you might be able to receive some of the general distribution funds. That's if you missed the June 3rd application, I believe, I have to go back and look, but I believe they have still created some sort of process based on when you receive the funds where you still may be able to go back and apply for that money. I'll have to go back and look to see specifically what they've released, but they had some new guidance pertaining to that. The bottom line is, if I were in a situation where, I thought that I had missed out on some sort of relief that I had received, I would call the Provider Relief Fund hotline that is provided by United Health Group, and I would speak to somebody there. I would also check and read the FAQ on the HHS Provider Relief website, which again is subject to constant changes and revisions and additions. And if you have any particular questions, make sure to contact me so that we can look up the latest information. But the bottom line is the majority of the money that HHS has to spend hasn't been spent yet. They continue to have a fund for uncompensated care. They continue to be in the process of releasing some sort of mechanism to provide relief to providers who are not eligible for the general distribution. So there are programs out there, whether assistance are forthcoming, that people still may be able to access funds through. But because, again, the HHS has continually been updating their provider relief programs, I would always encourage anybody at any given point in time, if they're curious about that, to visit the provider relief website that HHS has up, to contact us with any questions and to speak to someone on the HHS provider relief hotline if they're trying to get a hold on, potentially where their funds are at, or, whether or not they're eligible for some sort of program that's been specified there.
All right, thank you, Jarrod. That's right at an hour, so we cut it off. If you have any questions or questions you have not had answered, please email those to membership@flmedical.org. That is membership@flmedical.org for any additional questions. And Dr. Gifler, I'll turn it over to you for closing statements.
I want to thank everyone for participating, and I want to point out that we are in the process and will be in the succeeding months developing our legislative agenda for the coming state session, and we have a lot of insurance-related issues that we're going to be working very hard on and need your support. Thank you all very much for attending, and good luck.